ask before we finish up this lecture? We are going to, what I'd like to do after I finish the lecture is material is to actually review for the final exam. So for anybody who's interested, so where did we stop? Here. Harvey, Brittany, Cameron, this table, where it's the last thing you know. Oh. So we said proper presentation for delivery is head first, face down. Is that right? We understand that human, as far as in the animal kingdom, human deliveries are dangerous deliveries of males. And the reason is that we are bipedal. So it changes the angle of our pelvic bones. There's also, like I said, that pelvic outlet. The angle of that pelvic outlet, plus in combination, is narrow because we're bipedal, and plus in combination with our fetus's head size, human head size being one of the larger, it's a double kind of whammy that makes human deliveries the most dangerous deliveries of animals. Now with modern medicine, you know, our outcomes are good, aren't they? They're usually pretty good. And so it's important to have the United States doesn't rank these around the top even 20 as far as fetal outcomes. So that's kind of not good news. So we have a long way to go, even in this country, and helping women with prenatal care, and then also with delivery. So just something to be thinking about. You know, we think it's all about us in the United States, but it isn't. Then we still have a long way to go. So anyway, I think when we were last talking, we were talking about this chart and looking at in a 28-day cycle, women, how their FSH levels will be, how their LH levels will be, how that will actually also correlate with estrogen and progesterone. I'll talk about that in a second. And even how it correlates with the endometrial lining, right? We talked about endometriosis. Y'all know, what does that mean? Endometriosis. That means that the endometrial tissues, that inner lining of the uterus, these tissues have migrated out of the uterus. And there's still, these tissues are still going to be influenced by these different cyclic hormones and what they're doing. So this tissue, no matter where it is still going to be influenced by that. So we call it that. And we understood that this can actually lead to complications. And, you know, there's not just one presentation of somebody who has endometriosis or PCOS, polycystic ovarian syndrome. There's lots of different presentations of this. Some people have very, very mild, and some people, you know, whatever. There's a spectrum of this. The acute forms of this, though, can be, you know, very challenging for women to deal with. So we have talked about this. This estrogen and progesterone is being secreted by the ovaries. And what we said we know is happening the first day of a cycle is when the first menstrual flow is actually starting. That's considered the first day of the cycle. And what we know that menstrual fluid really is the sloughing off of this endometrium. Now, so that's the first day. We said that usually ovulation is around mid-month, usually. Not always. You can't really use that for birth control, but that's when it usually is, and most women, it's going to be mid-month. And we said it's because at mid-month, what is there a spike in? Luteinizing hormone. Luteinizing hormone is going to target this follicle to rupture, and it's going to release this this egg, if you will, this sac that has what will eventually be the egg. And then there is a period, it's a very few hour window where that egg has to be fertilized. If the egg isn't fertilized, then what is going to end up happening is obviously wouldn't get to the endometrium 6 days later to be implanted. It wouldn't get there, would it? So if that doesn't happen, then this endometrium is going to be sloughed off. But let's think about progesterone and estrogen and think about how they peak here late in this post-ovulatory phase. And the reason they're peaking is because it is the corpus luteum that's secreting the estrogen and progesterone. So this is secreting, peeking out the estrogen and progesterone. And if you do get pregnant, if you do have implantation happening here, you are pregnant, right? These levels will be maintained, they'll stay, and actually they'll start to rise. So if these levels are starting to rise, this is because of the corpus luteum. This is going to help sustain the first trimester of the pregnancy. It is dependent on that corpus luteum to be maintained. Now, if this stays maintained on an ultrasound, it's going to look like a cyst. Because what is a cyst? It's a fluid-filled sac. And guess what this looks just like? A fluid-filled sac. It really does. And so sometimes when people are having ultrasounds or whatnot, or pain or discomfort, they will go in and they will get examined and they'll say, oh, well, you have a cyst on your ovary. Is it normal to have a cyst on your ovary? It actually is normal. Every month on one of your ovaries, you're going to have this fluid-filled sac. Do you get what I'm saying? Do you hear what I mean when I say that? A cyst just simply means a fluid-filled sac. So when somebody hears that, do they usually panic? So actually, really, those radiology techs shouldn't say that. They probably shouldn't even say that, because that's going to make somebody who doesn't know what that's about actually really panic, and they shouldn't necessarily panic. Now, can they be abnormal? Can this fluid be too much? And when it ruptures, you'll hear people say, well, I had a ruptured cyst on my ovary, right? You'll hear people say that they've been told that. There's just so much more to it than that. And so, there are a lot of different things that cause these issues. But anyway, if somebody does have implantation here, this corpus luteum does stay. And actually, it's going to need to be there because it's going to sustain that first trimester, as I said. So anyway, these charts kind of go through each of those and letting you know on average how much blood loss there usually is during this time. As far as female sexual response, just like with the males, I'm not going to talk about it too much. Don't feel like that's really this class. But you can see in a normal mid-sagittal section illustration of how the uterus is in comparison to the bladder, the urinary bladder here. Some women, though, and this happens when women are stimulated, the uterus tilts back. So, and this is the only thing I'm really going to talk to you about this. Women have erectile tissue too, and I think everybody understands that, and glands for lubrication to help, to help with this whole process. But the uterus will tilt back here when there's stimulation. Some women get told that they have a tilted uterus, and it might be more difficult for them to get pregnant. That is a myth. That's not true. Has anybody ever been told that? Okay, see, that's what I'm saying. So please understand that is absolutely not really true. If anything, when you're stimulated, it's tilting back because is this actually getting more of an opening for sperm to actually enter? It really is. If there is a thinning of the mucus plug that's closing the cervix. And please do remember, I also said that that mucus plug is not a bad thing. That's a good thing because it closes off the cervix to potential infectious agents that could enter. And usually it's closed except for a very short period of time during the month. Okay, so gestation means pregnancy. We tend to think about pregnancies lasting, when we think about them, we say 280 days. But what we really know is that we're counting from the first day of the last menstrual flow. And do we think it really usually happens on that first day of menstrual flow, or do we think it happens 14 days later during ovulation? Does everybody go with that count? So even though we count it back 280 days, we know it's about 266 days because we take into account that first part. I have known some women who have gotten pregnant during their menstrual cycle. They knew they did. That they were having menstrual flow, they had very regular cycles, and that can happen. So again, even though we learn what's normal in a 28-day average cycle, please keep in mind that should not be used as birth control, right? Anyway, but let's see what else I'm going to talk to you about with this. So that's why it's predicted 280 days. We've talked about these 3 segments as trimesters, and I'm sure you guys have all heard about this. I've already given you the definitions for blastocyst, embryo, fetus, right, and then the neonate up to 6 weeks. So we've talked about that. I want to talk to you a little bit about these hormones of pregnancy. The first hormone that's going to be detectable is something called HCG. You will need to know that, human chorionic gonadotropin. So this is HCG. It's secreted by that trophoblast within 9 days of conception. So it's going to stimulate the corpus luteum. And these are going to be the levels that are going to be the highest. So I think this chart sort of shows you this. So you have ovulation. You have ovulation right here, and then immediately very detectable levels of HCG. When y'all hear about pregnancy tests, like over-the-counter pregnancy tests at drugstores, or going to a hospital and having a legitimate pregnancy test, they're looking at HCG. All of them are, whether it's the over-the-counter or the hospitals, they're looking for HCG. There's qualitative and there's quantitative tests for this. The ones that are in the drugstores, you know, and wherever you get them, they're going to be qualitative, so it's going to be positive or negative. But if there's suggestion that someone might be losing a pregnancy, might be spontaneously aborting, or what people call miscarrying, then they can be quantitative as well, where they can actually do counts of the HCG, not just a yes or no that it's present. Any questions for me about this? This is a type of estrogen. There's different forms of estrogen. So you're looking at how much estrogen and progesterone actually increase during the weeks after the last menstrual flow. And then I think everybody understands there has to be a lot of accommodation in a female's body with pregnancy. It's the trophoblast, so it's the early tissues of that. When the implantation actually happens, and I think we'll see a picture in just a second. We will in this next chapter. So when implantation happens, the tissues of the endometrium, there's going to be these little, almost like roots that go down from the blastocyst into the endometrium. And this is going to be where the placenta will actually form. So wherever the implantation happens in the endometrium is where the placenta is then going to actually be formed too. But in the beginning, it's very early tissues. Those very early tissues are what are going to be secreting that. They're sending signals back to the corpus luteum that, hey, I set up house here, so stick around, to the corpus luteum. That signal is the HCG. And then the corpus luteum continues to pump out estrogen, progesterone, helping to maintain it until the placenta can take over. I'm going to show y'all this, and you'll see this more in this next chapter. But as far as just adjustments to pregnancy, you will hear about, you know, pregnancy putting such a burden on a woman's system, and it is actually, you know, true. Blood volume can go up by 30%, certainly putting a strain on the cardiovascular system. The kidneys have to keep up with the filtering of that, as you can imagine. Late in the 3rd trimester, you can see where the fetus is taking enough space that even the diaphragm's having some trouble here. So you'll hear women who have issues with not being able to get a good breath or feeling tired. You'll hear about early on in pregnancies, it usually doesn't last the whole time, not always, but sometimes it lasts a long time. Women having nausea. The nausea that's associated with pregnancy is really idiopathic, meaning that people don't really know why that is. It is thought to be because of these changes in the hormone balances. This is referred to as hyperemesis gravidarum. Hyperemesis, what's it emetic mean? Emetic centers are controlling what? Emesis is vomiting, right? So hyperemesis gravidarum during the pregnancy. So this isn't just regular, what people call morning sickness. This is serious, like you truly cannot keep things down. So what's the risk of that? It's going to be hypovolemia if people are dehydrated. and not getting enough nutrients. So sometimes you hear about people who have to actually be admitted and get IV nutrients in for a bit of time and whatnot. It's pretty rare that that happens. Has anybody known anybody that that's happened to? No, good. So it is kind of rare, but every now and then you do hear about that. Most of the time it's just going to be a period, maybe 8 to 12, 14 weeks where people are, of gestation, are feeling a little bit nauseous, maybe. And I'm not sure why they call it morning sickness, because it can happen at any time, right? And some women, even though they may feel periods of nausea, they may never really vomit. The couple that's on this show, I told you I'd like you to watch, he was so empathetic to his wife, he was the one throwing up. Like I said, we need a new couple. Okay, they need a new but anyway, so, so anyway, hyperemesis gravidarum, that's what that's called. So there's a lot of adjustments that have to be made. You can actually see, obviously some of this that's happening. We'll see a little bit more of it when we talk about in the next chapter, just the gestation a little bit. So a healthy weight gain is typically considered to be around 25 pounds, but this is totally dependent on the health going in of the mother that's pregnant. So if you're talking about somebody who's of average height, average weight going in, then about 25 pounds is what they would like to see. If someone is not getting enough nutrients, what we do and tend to see happen is that the fetus is going to steal from the woman's body about what it needs. But what will typically happen is that there will be an early delivery. It is just nature's way that if a fetus is not getting what it needs in utero, there will be an early delivery because there might be a chance that that neonate will get what it needs when it's out. So when you think about premature deliveries, and there are things that we know can lead to premature deliveries, things that are teratogenic. Teratogen is anything that can harm the fetus. Certainly not getting enough nutrients would be something that could be harming the fetus, but also smoking. What are some other things? Smoking is teratogenic, it's harmful to a fetus. It's going to lead to premature delivery. What else? Drinking, obviously. What you'll get when you are have a planned pregnancy, or maybe it wasn't even planned, but you went for prenatal care, is you'll get a list of safe medications. You'll get this printed out list of safe medications. Guess what? Well, they have been approved to kind of take, but is there really any such thing as one that doesn't have any risk? So, but that doesn't mean that some women really have to have certain medications for their own health, right? But honestly, that is really the case. There is no such thing as completely safe, but there's some things we know to be really harmful. And so any alcohol? Like any alcohol? What do you mean? Like, I've had students who tell me that they've been told that by their OB doc that it's okay to have a half a glass of wine, because that'll calm their nerves down, which calms the baby's nerves down, right? Is that right? Well, that's what I've been told. But have y'all ever heard anybody say that their docs have told them that? That is absolutely time for a new doc, because any alcohol could be cause fetal alcohol syndrome, which means that new organism that's developing would carry that the rest of their life. That's a life sentence for them. So absolutely no amount of alcohol. Smoking is also teratogenic. Then obviously there's other things that are very much teratogenic to do. But okay, anybody want to add anything to that? The mother's blood volume increasing by about 30%. So you do see where this is going to, it does put a strain on the cardiovascular, the kidneys, respiratory. But I will tell you this, there's some women who have disorders going into their pregnancies, like autoimmune diseases, and sometimes even metabolic disorders, that they're the healthiest they ever have been while they're pregnant. So it can go kind of either way. And why that happens, I don't think anybody's ever really figured that out. So for some women, it really puts them at risk, but for other women, it can be the healthiest that they've ever felt is during that time. We know that some women will develop gestational diabetes, mellitus, right? So that means that now they really are in a high-risk pregnancy situation, and it's their fetus at risk as well. Yeah. So, all right. Let's see what else. So, some people have problems with their bladder. They can become, have frequency. You feel like they have frequency to urinate, but they also can have incontinence issues. So this can happen. There's something called the linea alba. This is going to be this line, this connective tissue line from the pubic region to the lower umbilical area. And this line can darken during pregnancy. So it's usually referred to as linea alba. You don't see it. But in some women, it can get really, really dark. And then they're called the linea negra, meaning black, alba meaning white. And supposedly, I don't know if this has happened to anybody that you know, but supposedly it fades over time. Is that true? I don't think. But anyway, I think it does. I think some people say that it actually fades. And then some people can get what's called this mask of pregnancy, darkening, almost like they have gotten suntan, but with sunglasses on. So you know how you see people who've had sunglasses on, but you can see that they've darkened, their skin's darkened in that. So this is referred to as kind of like a mask of pregnancy that can happen. Some women get this even if they're on oral or patch contraception. So some women, because what did we say contraception is? It's just low doses of estrogen and progesterone, right? And so that can actually affect the skin and do that and lead to that. So these are just some different things that can happen. Braxton Hicks is what people call false labor. These are painless contractions. So they can freak people out sometimes, though, because if you've never felt the uterus contracting, it's new or different. And so it's intense when a uterus contracts. And so they'll come in thinking, I must be in labor. But it's usually painless. These contractions are usually painless, and it's thought that it's the uterus practicing, sort of getting started practicing. We see it happening more in second and subsequent pregnancies, not so much the first pregnancies, but some women have it even during the first pregnancy. What else? Parturition is going to be the act of giving birth. That's just a term that means giving birth. And it's the fetus that dictates a lot of when the fetus is going to be born. Like I said to you, this is just nature's way that if a fetus is not getting what it needs in utero, the fetus is going to be stressed, the fetus will be secreting cortisol, and this will initiate labor situations. So 40 weeks, and I do want you all to know, 40 weeks is considered full gestation. 40 weeks, not 36, not 38, 40 weeks is considered full gestation. So people who actually want to pick their birth dates, I don't know people who pick the birth dates of their fetuses. Yeah?
We will possibly do.
You said you did. Did you have a say in it?
No.
So anyway, some people do, but hopefully they have an OBGYN or they have a practitioner, a midwife or whatever, that's really kind of talking them into the idea that every day in utero is an important day. You don't want, I don't think in this country or in these developed countries, they let people go past 42 weeks. So that 42 week is that period that time's up. You need to go out, right? So, and the reason they do that is because what we see happening is that usually nothing great happens after the 42nd week. Usually we start to then see a decline and mortality rates going up because there's only so much room and there's only so much amniotic fluid being secreted. If amniotic fluid starts to decline, the output of amniotic fluid, the fetus is at risk. So there really is, just looking at numbers, not great things happening after the 42nd week. So I don't think there's any practice that is allowing women to go past the 42nd week. But we really want everyone to get to the 40 week. So, okay. We know that oxytocin is going to be what actually starts labor, isn't it? The oxytocin is going to be secreted from where? The pituitary is made in the hypothalamus, stored in the pituitary, released from the pituitary, targets that uterus to contract. And we know that when that happens, this head is going to be pressing against the cervix because the uterus is pushing. It's going to be pushing, and the way that it typically feels is that it starts to contract from the back, and then it moves around the front, and then it's like, boom, as like a typical feel for how that does that. And it's, it's really effective because it's going to push this head into the cervix, causing this third cervix to start thinning. And it's going to, as the cervix starts to open, it needs to get to 10 centimeters. And y'all can picture like 10 centimeters. That's a significant thing. OBGYN practitioners get really good, because obviously they can't see inside, right? So they get really good at knowing like where their fingers are. That's like 2 centimeters, 3, 4. They get good at knowing that. They can even do like half, figure out what's half centimeter. Because you know we hear that you're like 8.5 or 9.5. That's no fun to hear. But anyway, they get good at that and they know. Here's the thing about labor. When you think about early labor, this is going, and actually it's just early part of childbirth. It's not even considered labor really, is to get to the 10. Once you're at 10 centimeters, the cervix is open. Maybe you all can see if any little part of the cervix is still present in this canal, if it hasn't moved away, you can't have the person pushing. And what do we tend to do if we're in pain? What do we tend to do? We tend to hold our breath and tense up. And when you hold your breath and tense up, what are you doing, even inadvertently? You're pushing. And you should not be, because if this tissue is trapped, it actually will block the birth canal. And it can start to swell. And that tissue can actually start to be harmed. So this is going to impede labor. You don't want somebody pushing. And the bad thing about when you're in pain, you do tend to, whether you know it or not, hold your breath. And the pain of labor is all completely from lack of oxygen to the mitochondria. Let me say that. The pain of labor is, you're not right now, but I just want y'all to hear that. So what should people be doing during these contractions? Really breathing. Breathing's going to be important. I don't mean that Lamaze panning breathing. That's where did that come from? Anyway, it's just really deep, relaxed breathing, because that's going to help with the pain of labor. But it's really hard to do that when you think you're dying, okay, and you think that this cannot possibly be. So, or people, mostly, the only people who really think you're dying are people who have gotten enough support to understand the process. So they're afraid, aren't they? And they don't really realize that this is not going to last forever. And even the waves of contractions, you always get a break in between. Or they might have learned that in their classes, or learned that, or been told that, but they don't believe it. They realize, and so they panic. And then when you panic, you're not breathing, and you're pushing. And this is a bad thing. If you really can listen, if you're not taking it, they've been given enough that you can't interpret it. If you're really listening to your body will tell you when you're at 10 centimeters. You don't really need to have somebody with their fingers feeling it. You'll know, because your body will push. And it's just a kind of a weird thing that happens just like that. But anyway, the pushing part, as the head is coming down, it's turning face down, or should be. Sometimes when it's not doing really like that, it can be what's called back labor, right? But you all know breech deliveries now, and a lot of times in this country, are not even happening because of litigation, because people will sue you, So people are having C-sections when a fetus is butt first, or feet first. It's usually like butt first or feet first, or sunny side up, hand first. So that's just the early stage. The real labor is pushing. And the good news about pushing is that the good news about labor and pushing is it usually only lasts about 30 minutes. And so, because it's work, it's kind of work doing that pushing. The uterus is doing most of the work, but obviously, what position you're in and you can actually push to can help with this as well. So that is the good news, is that that's usually only lasting about 30 minutes. The placental stage is also incredibly important. So after the head is delivered, so usually when this head is delivered, it's done. It's just really everything's kind of over. The perineum at this point, when the head's crowning, is you'll hear about sometimes a ring of fire that can happen because it's kind of feeling like it's on fire, burning a little bit. But then it's kind of numb, really. And so when the head is delivered, usually on the next push, you want to be controlling this because this can all happen kind of too fast. And on the next push, the shoulders, and then the fetus like that. So, and then it's going to be really important about that placenta. So in a licensed facility, the placenta, once it is delivered, this placenta is delivered, they're going to send it to pathology. It's going to be examined right there, but it's also to make sure that it's intact, but it will also be sent to pathology so that it can be really examined well to make sure that it was intact. If any little piece of the placenta is left behind, or any tissue is left behind this uterus, then it can necrose. And if necrosis happens, because it's going to be kind of stuck in there in necrosis, it can be life-threatening. So, even if it's not life-threatening, if they catch it, but then have to go in and do like a D&C and stuff, and you will hear about this if you look this up, they will usually have to, it's such an emergency situation, remove the uterus. So then this woman is going to not be able to obviously have any other after this. So this can be a life-threatening thing. So it's important to understand the placenta and understand about how to take care of that as well. Any questions for me? Just basic questions for me about that. So it's kind of amazing, but what can happen is the mother's anatomy goes back pretty quickly. So within 4 weeks, especially if a woman is breastfeeding, why would breastfeeding help the uterus to get back in shape quicker? What does breastfeeding encourage the cyclic secretions of? What do you say? Which ones? Oxytocin. So with breastfeeding, it's not just prolactin that you're secreting to make milk, but women are staying on an oxytocin cycle too to eject the milk. And that oxytocin isn't just ejecting milk, it's also getting that uterus back into pre-gravid or pre-pregnancy shape. So there is something that's happening that's got a lot of lysosomal enzymes. It's called logia, this vaginal discharge. So and new mothers need to be, sometimes they'll be a little panicked at this discharge. They won't really think that this is normal, but it's normal for that to be happening. Breastfeeding is promoting that involution, suppresses estrogen secretion. We know that some people in some cultures use breastfeeding as a form of birth control. Is this really a recommended form of birth control? No. So, no. But anyway, usually, though, sometimes it really can be a natural form of birth control because you are usually going to be not ovulating for that time. But a lot of times now in developed countries and cultures, people aren't just exclusively breastfeeding. They're usually doing something else. If you're letting somebody, you pumped, or you let somebody else feed a bottle, or you're supplementing with any kind of thing, then certainly it wouldn't be, and it's not advised to be a form of birth control. Would you say? You know, they really don't keep you from ovulating. They don't. Yeah, I know people make jokes about, you know, taking care of newborns or babies as being a good form of birth control because you realize how much birth they have. I'm not saying
That's not correct.
yeah, it's not. So anyway, colostrum is going to be that what we call that first milk. That first milk that's actually being excreted or being secreted is actually really kind of golden looking, and that's normal too. And it's really high in carbohydrates. So this is going to help. It's going to have less fat, thinner. It's going to be full of IgA antibodies of the mother's antibodies. So that those first few days, even if someone doesn't want to breastfeed, they could just do the first few days to get this. It coats the neonate's GI tract with these IgA antibodies from the mother. And those antibodies can really protect that newborn from potentially getting GI issues. So this is whatever, but people should do what they feel the most comfortable about because it really is about the baby's health. And I think that sometimes women can feel pressured to breastfeed that aren't comfortable breastfeeding. And, just the fact of the matter is some women will never really get enough milk through breastfeeding. So sometimes it can impact it for them. It is a very natural thing to do, though. It is a easy thing to do if you have enough milk. There are some women, though, that have involuted nipples, so their nipples won't allow them to, or they have very sensitive, dry, cracked. So it can be painful for them. They can have psychological reasons that they don't want to breastfeed. They may feel uncomfortable about it. And if they do, it's really not about them. It's about the neonate getting what it needs, right? You'll have babies come into your ER that are about this close to having hypovolemic shock, and you're losing them because they weren't getting enough from breastfeeding. And you'll have mothers that care deeply and want to be doing it, and they've been pushed to try to breastfeed, and they just haven't been able to do whatever. So I think it's all about education. But in the perfect world, it would be great if breastfed because is it the best for the baby? Obviously, it is. But there are alternatives too. So there's formula, and so people need to just know that they have that. The prolactin spiking, you can see with each serving during each breastfeeding sessions. Prolactin, we said, from the pituitary, targets the mammary tissue to actually make milk. The ejection, we said, is oxytocin. So you guys know that. You know that that this letdown response is actually going to be because of oxytocin. That actual pumping, that like the milk is just pumping out. It's going to be because of that, the letdown response. And looking at the comparison of colostrum, human milk, and then cow's milk, you can actually see the different comparisons. And certainly, like we said, in a perfect world, people would breastfeed, but not all people can. So there's no guilt associated with that, or should be. There's some people who get made to feel very guilty about that. Have y'all ever heard that before? And you probably heard people who've been made to feel that way, and that's unfortunate because it shouldn't. It shouldn't be. There's something called the late leachy leaf. Have y'all heard of that leaf? Who's heard of the late leachy leaf? What have you heard about it, Jan?
Like breastfeeding.
Yeah, so usually there's like leachy people that are in hospitals and clinics, and they're going to come around and really they really advocate that you try breastfeeding. And I think sometimes some of them are really, really good, but other times some of them are really pressuring people to do breastfeeding. All right. And by the way, breastfeeding kind of it runs in cycles as far as cultures and what they do. It was a time like all my friends breastfed if they could, the ones that could. But the generation before me, it was considered like no one would have done that, would have breastfed. You know what I mean? So does anybody know that about their own parents? So, well, maybe not, because your parents would have been younger than you. So they were probably encouraged to breastfeed, right? Is that right? Is everybody's parents in here, were they encouraged to breastfeed? Not parents, but the mother. The dad would help. Dad was not helping. No, yes, they do help. They have to help. I'd be supportive. Okay, but it kind of does. It's a cultural thing, isn't it? And then there's some people who get all bent out of shape if they see somebody breastfeeding in public. It could not be more natural than you know, that's the most natural thing in the world is to breastfeed. I'm not saying all out and open. Most of the time you wouldn't even know somebody's breastfeeding, holding an infant, right? But if people aren't really comfortable, it can affect how much milk is getting produced. So, okay, in chapter 29, this is really about, embryonic development, but also about senescence, which a lot of this stuff is already covered, and some of the hormones. But it's just very little bit in this chapter, but I will talk a little bit about some of this. How many sperm will fertilize an egg? How many does it take? It's only one. And again, this is one of the best parts of that little film, I know the PBS that I really want you to see, because you actually can see the sperm trying to get into the egg, and the sperm is delivering half of the chromosomes, right? The egg is huge in comparison because the egg has all the cytoplasmic inclusions that are necessary for the zygote, if the zygote actually happens. But once the sperm that is accepted enters into this zone here of the egg, the entire egg will wall off. No other sperm obviously would be allowed in after that. So it's kind of a cool thing to watch on that movie. It is that little documentary. It is definitely by far and away the best part of that documentary that you would get to see that. So, this tells you a little bit about the process of the egg, and then also how long it's staying around, and this window of time that you have for the egg and the sperm to live. Obviously, sperm live a lot longer than eggs, right? And the sperm have a long way to go. When we look at sperm, the difference in a sperm that has an X chromosome and a sperm that has a Y chromosome, right? We see there's some differences in those sperms, actually. The X sperm, the ones that have the X are usually a little bit slower moving, but they last longer. The ones that the Y are faster, but have a little bit of a short. That's just sort of FYI that people have sort of figured out. The new cell that's formed is a zygote. The first few weeks we had said, the first couple of weeks we said is a blastocyst, and we had talked about it taking a good, 5 to 6 days. Here you're seeing how this blastocyst enters, and you would see this on this film too, this documentary, where this little group of cells come into the uterus, lay down, and then actually it looks like the endometrium just covers it up. And that's implantation. Wherever this happened is where the placenta will form. If the placenta forms here, what is this placenta going to end up blocking? The exit route. This is actually called placenta previa. Placenta previa, back in the day, way back in the day, was a death sentence to both the fetus and the mother. This was a death sentence. Now, placenta previa, this is going to be seen on ultrasounds. It's prenatal care, isn't it? And it's going to be a scheduled what? Exactly. So this is going to be good news, right? Modern medicine, good news. But placenta previa is when the placenta is blocking the exit. Now, sometimes the placenta is in a great place and everything's progressing well, but the placenta can actually unattach from the endometrial lining. And so this is called placenta abruptia. So that again, back in the day, would have been what? That the female would have bled out during that time, and the fetus would have died too before delivery could have happened. But now it's going to be an emergency delivery, usually an emergency C-section, right? So, so these are some situations that can just happen here. Y'all have heard of You guys have heard of some testing that can get done. You've heard of chorionic villi sampling. You all know about karyotyping, right? You did karyotyping in NP1 where you diagnosed a disorder. The cells that are used from the fetus for doing that karyotyping can be done using chorion of where this attachment actually happens. So that can be done as early as 8 weeks of gestation. So they would just do using a pelvic exam with the speculum. They would take a very fine needle through this opening in the cervix and actually take some of the chorion, which is going to include fetal tissue, and can do a karyotyping as early as like 8 weeks to detect if there's any sort of chromosomal anomalies or abnormalities. Like I said, don't get karyotyping. Now, later on, and I think we'll have a picture here soon, around 16 weeks, they can go in from the abdomen with a needle using ultrasound to find a pocket of amniotic fluid. And they use the ultrasound and they go in from the abdomen on the outside, through the abdomen, through the uterine wall, into the amniotic sac and pull out amniotic fluid. They don't want to hit the fetus. They don't need to touch the fetus. They just need amniotic fluid because the fetus is swimming in this fluid and there's going to be skin cells in that amniotic fluid from the fetus. They keep them alive, keep them growing, get them in metaphase of mitosis and are able to do karyotyping from that as well. So twins, we hear about twins occasionally. We hear about twins a lot more now because people end up going on meds that end up causing them to ovulate more than once. And so we hear now a lot about more twins than would be in a natural setting. But anyway, dizygotic twins means there are 2 eggs that are formed. So in this situation, a woman didn't just have one follicle that was stimulated, she had 2 follicles stimulated and produced 2 eggs. There's some women who routinely do that each month. They produce 2 eggs. Those women have a much higher risk of having dizygotic twins. It does take 2 individual sperm. These twins are no more similar than any other siblings with the same father. So they're really no more similar genetically. Now, it could be definitely argued that they have more of a bond, and I would think that I've seen that to be true just myself. But anyway, because they are raised together, so environment also plays a little bit of a role in that too, don't it? But as far as genetics, they're no more similar than any other 2 that have the same father. Can someone have dizygotic twins with different fathers? Yes. How? So it's instead of having just one male that contributed sperm, there's a sperm pool. Right? So, and I'm not meaning that it just is, and so it can happen, and it has happened. So that actually can happen. Now, monozygotic twins and again, this is something you see on this film. There's a lot of great things about that first part of that film. Anyway, you'll see this happen where you'll see a developing blastocyst. It's a developing blastocyst, 1 egg, 1 sperm, and then all of a sudden, instead of it just developing into one, the whole little group divides, and that's called identical twins when that happens. They have the identical DNA fingerprint, don't they? Now, there's some controversy associated with identical siblings, and we have identical siblings in here which are special, so special. Y'all have identical DNA fingerprints, but you don't have the same actual fingerprints because, and this is controversial because once you all split, at that moment, and you should watch them so you can see where that happens. Once you all split into 2 separate, blastocysts, you are being influenced by different factors, slightly different factors. And for the rest of your life, you really will be as well. So we do know our DNA dictates a lot of what goes on, but not everything. Environment plays a role too. So I do think it's special, doesn't it? Special. Okay, so triplets, quadruplets, can even occasionally occur from that. I talked about implantation, didn't I? So I had talked about implantation. And so you see this kind of parts of the tissue here, Dylan, in this slide. And you can see how these little finger-like projections, once it hits this cystic blastocyst, it's the endometrium, that will start to send out little fingers into that and actually be taken in. I think everybody in this room has heard of an ectopic pregnancy, haven't you? An ectopic pregnancy back in the day was a death sentence. Haven't we really come a long way? It is a life-threatening emergency for a woman who has an ectopic pregnancy. She will die if there isn't surgical intervention to remove it. If it's in the fallopian tube. Let me back up and say, if it's in the fallopian tube. Ectopic means outside of where you expect. So this is a pregnancy outside of the uterus. And in most cases, it's in the fallopian tube. So what happens is it starts to block that fallopian tube, and the person's going to eventually it's going to rupture it, and they're going to bleed internally. And without medical intervention, this is a death sentence. But people do get medical intervention because, for one thing, it's incredibly painful. And so they're going to end up, is pain a good thing or a bad thing? So they're going to end up seeking medical help, and they're going to have emergency surgery, and they're going to remove that developing blastocyst and remove that fallopian tube. Some women then think, well, oh, now my chances of getting pregnant are going to be much less. But actually, there are many women, after having an ectopic pregnancy and the removal of one fallopian tube, don't they have a whole other side that's working? Usually. Now, here's the thing. Whatever blocked the fallopian tube on one side, sometimes, and they can study this, they can see, they can go in and check and let the person know if the other fallopian tube is blocked. But sometimes the blocking of the fallopian tube can happen because of infection. And if it's blocked on one side, is it a higher chance that you might be blocked on the other side too? Yes, that can happen. But then still, there are other things that can be done now with fertility. They can harvest eggs. They can do in vitro, fertilization. They can, help with that if that ends up being the case. So, any questions about that? But that's what that means. But you guys, I have never seen this happen. We could Google it now, though. We could probably find something. But on rare occasions, you know how I told you that endometrium can actually move out of the fallopian tubes into the pelvic cavity? On rare occasions, these developing blastocysts can move into the pelvic abdominal cavity. And on rare occasions of those, they can develop. And so you can see. Now, it would have to be by C-section delivery, and it would be an incredibly virus pregnancy. But why would it have to be by C-section? Because there's no exit route. There's no exit route, right? So again, back in the day, ectopic pregnancies were 100% fatal. So medicine has come a long way. People would, I don't understand in 2019 how there would never be a planned pregnancy. But anyway, planned pregnancy, good prenatal care, So we said 2 to about 8 weeks, and y'all are seeing, you're seeing chorion here, but anyway, y'all are seeing what this looks like, and this kind of goes through showing where the placenta actually is developing, and different types of pictures during this development. And I've got some little models too, so if you would like to see this. So fetal, and it talks about fetal development and fetal organ systems. So this gives you just sort of an idea. Around the 8th, 9th week, all organ systems, this does not mean they're all functioning, I didn't say that, but they're in place and they're distinctive around this time. So we hear about these markers, like 21 weeks so far. I think 21 weeks is still the earliest fetus that has been delivered that has survived. I don't think any younger than that. Has anybody heard any younger than 21 weeks? So 21 weeks. And when I say survived, I meant when, extraordinary measures being taken, extraordinary measures. Now, the ones that can survive are typically maybe going to have some lifelong consequences of being delivered that early. But you will hear about the whole term is 40 weeks here. You will hear about this 32 week as being that week you really want to get to. And the reason is, again, a lot to do with like statistics, but at 32 weeks is when we tend to see less chance of respiratory distress in the newborn, which is because of immature which cells? Great alveolar cells that aren't secreting what? What's that product? Surfactant. Go back and review things, right? So surfactant, so this 32 weeks is kind of considered that week you'd like to get to. I've seen baby boys, males have more of an incidence of this, born at 38 weeks, so that were like 8 pounds that didn't make it. And they did make it because of respiratory things. So, it's really weird. You'll end up seeing like 28, 27-week-old fetuses making it with extraordinary measures being taken, making it, and then something like a 38-week, big baby not making it. So there's that you can't even define quality that might be there that keeps one surviving and another not surviving. But what we'd like to see, every day matters. Every day matters. It's so important. There's so many women now demanding early deliveries or trying to demand certain things that they put out public safety announcements on commercial TVs. Have y'all seen these? Where they try to tell you every day gestation is an important day, right? I'm not sure why they have to do that, but anyway, they do. They're putting that out for so many people trying for that. Okay, so this IgA we said protects against gastroenteritis, which babies are the most at risk for not being able to thermoregulate. They can't control their temperature, body temperature, so you have to be very cautious of understanding what the ambient air temperature is to help them. And then they can't maintain glucose homeostasis. This is why you don't let them sleep for long periods of time. You help with that by keeping glucose down, feedings kind of regular in the beginning. And there's just a lot of different things going on. But anyway, thermoregulation, fluid balance. Premature babies used to be done by weeks or so, but now they really kind of talk about weight. So they talk about weight. So there's more than just gestational age. It's also going to be weight that they look at with these. Were any of you all preemies? Oh my goodness. Okay, like how preemies? How preemie? You've got a twin? Trevor told me that. Are y'all identical? Or that means I got it. So y'all were what?
3 pounds.
Y'all were 3 pounds. How many weeks?
How much?
Twins are often delivered early. Not always, but often are delivered early. And the reason being, it's more of a stress on the mother. So the twins are typically giving off cortisol. And so the mother will go into labor early. So it's usually kind of an early thing. How early do y'all have?
I think we were 38 weeks.
Okay.
But I was 6'6" and Anna was 6'7".
Yeah, that's good.
We were
A lot of it when you see twins, because usually that's the case. Usually it's the case where they're, if you can get them to 5 counts, you are just golden.
Yeah, mom was on bed
twins.
rest.
What'd you say?
I think mom was on bed rest.
Yeah, so Chris, she did it. So tell her, go home and tell her, give her a hug and say, oh God. But it's really hard because it's more of a strain on the mother. How early?
I don't remember the weeks, but I know it was
5 pounds. So now that would, kind of they don't, as long as you're 5 pounds and over, they're really happy. You were like, well, anybody else? How early did you?
I was 26 weeks.
Oh, wow.
Yeah,
Wow.
I was 2 pounds 2 ounces. I went down to 1 pound.
Do y'all know what a neonate looks like at 2 pounds?
I look like an alien, like a little
Alien, that like in the palm of your hand, that's so tiny. So that's very early. Do you know why, or was there any reason they ever figured out?
I was pretty healthy. It was my mom. she just, like, they wouldn't even listen to her. She was like, I'm in labor. And they were like, oh, you're obsessive. You told my dad to go home.
Were you the
Like,
first?
No,
Her first?
no. My
Yeah.
brother,
Yeah.
he was born early too, but it was something.
Yeah, yeah. So, it can be a stress, it's considered to be a stressor on a woman's body. So it really kind of is. Well, listen, so glad you're all here with us. And, that's great. So anyway, this class is not about legal. I'm not talking about any legal things or whatever, because we're just 5% of the world's population. Really, it's not all of us. But there is, I think, 24 weeks is considered to be the cutoff. And there's so much misinformation about all that. So I would just strongly encourage everybody to get the correct information about what they call late-term abortions. And no one, by the way, is killing a fetus. But a fetus that is delivered alive, no one's killing. No one. That's just misinformation. Yeah, go ahead, Casey.
Share.
Well, so some had the same exact whatever. So it would just depend on the development of how, but not dizygotic. No, dizygotic are absolutely separate. These are separate whole little packages, if you will. So you can have dizygotic twins of different gestational ages, which is kind of obviously a high-risk pregnancy, because usually that doesn't happen because of inhibit. When a woman gets pregnant, then she's not going to be producing FSH, so there's not going to be a follicle the next month. But sometimes because of inhibit and progesterone, but sometimes women will, so they can have of different gestational ages. So you will hear about dizygotic twins because the fetuses are getting their nutrients through the placenta. You will hear about them being born at different times. So they'll deliver. You can imagine how high risk that is. There's a lot they can do in utero. It's amazing to me. And I'm not even up on the newest, but even 25 years ago, they could go in utero and operate and fix spina bifida. And when the fetus was born later, there wouldn't even be a scar from surgery. In utero surgeries, this is interesting too. In utero surgeries that are performed are obviously high-risk procedures, but there's the surgeries that are performed don't leave scars behind. So there's just a ton of stuff that can happen. You hear about this area of medicine as being the best place in the world to be until it isn't. Until something goes wrong, then it's one of the worst days. One of the worst places. Okay, so we talked about things that can be teratogenic. Teratogenic is anything that can harm the fetus, and so we've already talked about some of those. We know that there's some things that can happen. This was covered in the karyotyping, but in a normal situation, you're going to have, a parent cell that has a pair of chromosomes, and when gametes are formed, it's going to be, again, this is a normal situation happening where you have like a female and or a male right here. But there's something that this is called normal disjunction, but in non-disjunction, then you're going to have differing numbers of chromosomes, not 45, 46. You're going to have, like in this case, 45. And you guys, we saw this, didn't we, where Turner syndrome had 45 chromosomes, because instead of having 2 X's, this individual only has 1 X. I had a student a couple of semesters ago who had Turner syndrome to share it with the class. These are going to be females that will never develop reproductive systems that are going to be functioning, so they're sterile females. They're sterile females that are normal intelligence and whatever. Sometimes there will be some physiological anomalies that happen that causes some webbing at the neck or some other issues, and then certainly they are infertile. But this is Turner syndrome. Triple X is another situation that can happen. You can see that these are usually infertile, but they are usually intellectually impaired. So there's going to be some developmental delays. That Klinefelter, we saw, said that some people don't know they have Klinefelter, and some Turner syndrome don't know they have Turner females until they hit puberty. And then they really never get those secondary sexual characteristics we have in female, with the breast development. They don't, have menstrual cycles. So then they go find out that they actually have Turner. Same thing can kind of happen with Klinefelter with some men. They can have this, and this leads to infertility. Intelligence is average, but they can have underdeveloped testes if somebody's paying attention to that, So anyway, but some of them don't know until they try to figure out why they're not able to reproduce. And then these are sex chromosomes. The only one that's viable, the only one that can survive, that's of the first through the 22nd pair, is Down syndrome. No other non-disjunction is going to be viable. Again, I had a student last summer in the South Boston area. Her sister had a non-disjunction of I think it was like 14. And they were letting that develop, that fetus develop, and there was zero chance it was going to be a live birth. And it wasn't. And she carried it till almost like 8.5 months, and then it died. So that was hard. So anyway, but the only one viable of the first to the 22nd pair is going to be Down syndrome. And y'all all know that's called trisomy 21. Why is it called that? Because at the 21st pair, what do you have? Do you have a pair? No, you have 3 chromosomes. So instead of 46 chromosomes, there's 47 chromosomes, because at that 21st pair, there's 3 of them instead of 2. And this is the only one that has been shown to be a viable delivery. The Down syndrome, you really wouldn't have to necessarily look and see this on chromosomes. You can see from physical anomalies that this is a syndrome. There's something called the simian crease here, the single palmar, the thumb palm, the single crease. Epicanthal folds. Epicanthal folds are also normal in some, like the Mongolian race. The Mongolian race have epicanthal folds. Asians have epicanthal folds. So Down syndrome, I don't know if you all have if you even know this, but you could Google it and tell you can see I'm telling you the truth. Down syndrome used to be called Mongoloidism. But the Mongoloid race took offense to that, because the Mongoloid race, it's normal to have epicanthal folds, isn't it? So they took offense to that. So obviously people have started to change that and refer to it as Down. But that's what an epicanthal fold looks like. And so if you have parents that don't have this, or not of Asian descent, or have epicanthal folds, and you see this infant that's born with them, then this is a real clue. Same thing with some of the digits. So even physical things kind of show this. Now, look, aging, we talked about what aging can do, right, to our organ systems. We said this is just a natural process of life, just like death is a natural process of life. So anyway, senescence is this whole idea that's related to this natural process of aging. Can exercise help you to keep quality of life and quantity? If, go figure. We found out all along the way that we need to be sleeping, right? Sleeping, diet, and exercise. It can really help with all of this. Now, a lot is coming out right now about what death actually means. Do we die at one split-second moment? Is death just in one moment? No. So you hear about in medicine, and you will probably be involved with a calling of the time of death. But do all the tissues and organs die at the same time? No. So we do tend to think about that death is when there's been no brainwave activity for 24 hours, and that can be considered to be clinical death at that point. But there's just different things that happen. I think a lot of medical professionals that have seen or been with people at the time of death would tell you that there is a distinct difference of energy in the room when that person has lost their life, right? So there's this just undefinable type of thing that happens. So, any questions for me? These have kind of narrowed down and kind of averaged here. Women have lost a little bit, and that's for a lot of different reasons. So maybe a couple of years, and then increased a couple of years here, and it's kind of equal now as far as average lifespan. Average lifespan is 14 months. So, questions for me? Hey guys, y'all are finished with me. Who's happy? Go ahead and cheer. You can cheer. It's okay. Okay. Look, what I'd like to do is, right, and if y'all want to come back for kind of a quick little review of hormones and disorders, I'm happy to do it with you. Okay? If you don't want to stay for that, you don't have to. But if you want to, I'm going to be here for you in about 10 minutes. Okay?